Hi, my name is Dr. Matthew Weiner. I'm a bariatric surgeon. I'm the medical director of the Michigan Weight Management Institute. And for the next 45 minutes to an hour, I'm going to talk to you about bariatric surgery and actually obesity as well, the causes of weight gain and what's necessary for weight loss. My hope is that after you finish watching this, that you have a much better understanding of what bariatric surgery can do and what it can't do. And I think even more importantly, what is necessary as far as the behavior changes and the lifestyle changes in order to ensure that when you have that surgery, you lose all the weight that you can and you keep it off for the rest of your life and improve your health. So we're going to go through these slides, and if you'd like, you can always call my office and come in for a consultation where we can discuss things further. This is really just meant for education. And I love it when the patients have seen this before they come in for their consultation, because we can really hit the ground running with our conversation. So we'll start by talking about the definition of obesity. And this is important because this is what your insurance company will use in order to measure your obesity and determine whether or not you actually will even qualify for the surgery. It's a two-digit number. It's called the BMI. And it's essentially your weight divided by your height squared. And the only tricky part of this is that you have to convert your weight and your height from pounds and inches into meters and kilograms. And there's a million calculators on the web that you can use for that purpose, and I would encourage you to get online. Obviously, we'll be able to help you out with that in our office. The one thing that we know about BMI is that it's actually a really accurate measure of your chance of dying every year, unfortunately. We know that as your weight goes up, your chances of developing specific diseases will increase as well. And this chart right here shows that if your BMI is between 20 and 25, which is the normal level, that you actually have a fairly low chance of dying. Obviously, as you get older, that chance will go up, but of all people, if you have a BMI of 25, you'll have the lowest chance of dying in your age group. That 25 to 30 range we can talk about. This graph shows that it's a little elevated. There's been some recent evidence that says that it's actually the same, if not a little lower. Where the exact truth lies is probably somewhere in between, but it's pretty clear that for most people, if your BMI is between 25 and 30, it's not going to significantly impact your health. It's once we get to 30 and above, and there really is uniform agreement on this. This is not a debatable point. Once your BMI hits 30, your chance of developing certain medical diseases starts to go up precipitously. And the higher the BMI, the greater the chance of developing high blood pressure and diabetes. And this next slide actually shows the list of diseases. We call these comorbid conditions. This is a list of the medical diseases that you can develop from being overweight or obese. And if you look at these conditions, it really essentially is it's responsible for about 80% of all the doctor's visits in the country. When we look at your lungs, we see sleep apnea, which is an extremely common disease. In the heart, we see high cholesterol, high blood pressure, heart failure, heart attacks, much higher incidence as your BMI goes up. We see gallstones and fatty livers and hernias. We see musculoskeletal issues with arthritis and the need for knee and hip replacements. We see urinary stress incontinence. Something I see quite often in my practice is infertility, and I actually have a lot of patients who've been able to conceive and deliver a healthy baby after their bariatric surgery when they were having difficulty doing so beforehand. And it's with that 100 pounds of weight loss that they improve their hormone balance and are able to conceive. We see higher rates of skin infections. We actually see higher rates of cancer, and I think this is actually something that a lot of people don't consider, but higher rates of breast cancer and prostate cancer, two very, very common cancers. We see this increase as your BMI goes up. And then what most people are afraid to talk about, but without question is absolutely true, is the psychological issues. My personal opinion on obesity and emotional eating and the psychological issues behind it is that certainly there are a subset of patients who develop their obesity as a result of anxiety or depression. But I think there's a much greater metabolic component to it. As I often tell my patients that you don't have to be crazy to become obese. But being obese will certainly make you crazy. And that's because the world looks at people who are overweight as having a fundamental mental weakness and not being of the same value as people who are normal weight. And as you look out in the political world and in the business world, you see people who are incredibly disciplined in their lives, are able to achieve amazing things, start businesses, change the world, but cannot change their weight. And the reason for that is that this is a metabolic disease that physicians have not really gotten a handle on fixing. Bariatric surgery is our first step in that direction. And I think over the next 20 years, you're going to see some pretty amazing things happen. But at this time, what we have is bariatric surgery alone as physicians to be able to reliably change people's weight. So let's talk about what most people think is the absolute golden rule of weight gain and weight loss, an indisputable fact, which is that you gain weight when you eat more calories than you burn, and you lose weight when you burn more calories than you eat. And although that is a true statement, what people then say next is absolutely and totally categorically false. And I'm hoping that these next couple slides will prove that to you. What people say as a result of this fact is that therefore you should diet and exercise. And by diet, what they mean is eat fewer calories. Smaller portions, low sugar, less calories, less often, and exercise by going to the gym and getting on the treadmill for 30 or 40 minutes and burning off those extra calories. And if you're going to believe this statement, then you're going to really struggle with your weight, because quite honestly, diet and exercise do not work in about 95% of all people. And I'm going to explain that to you. And I think this is a little bit of math on this slide, but it's something I see quite often, and it really drives home the point that there's some metabolic problem here rather than a conscious decision by individuals to eat more than they should. This is a patient I see in my office all the time. Probably once a week I see this woman. She started out at age 20 at 130 pounds. Between jobs and stress and marriage and children, she gained 100 pounds and is now 230 pounds at the age of 40. And when you look over it, certainly there was a little more weight gain around the times of the pregnancy and the births. And there were periods of weight loss only to be followed by weight regain. But if you look on average, for the most part, this woman gained about 5 pounds per year steadily over 20 years. And that's a pretty common way. Not everybody gains their weight that way, but it's fairly common to see. So when we break this down and we use this calorie in, calorie out model, well, 3,500 calories are in 1 pound of fat. And that's true whether you, say, have a 16-ounce bottle of olive oil, 1 pound of olive oil, there's 3,500 calories in that olive oil. By the same logic, you would need to burn 3,500 more calories than you eat in order to lose 1 pound of body fat. So if we take that, which is, I think, an irrefutable fact, we recognize that 5 pounds is 17,500 calories. And when we do the math on how many calories per day this woman must eat to get these extra 17,500 calories, we are left with only 48 calories. That is like half a slice of bread. It's one of those lunchbox apples. You can burn that off by running up a couple flights of steps. This is an exceptionally small number of calories. Yet only 48 calories a day has caused this woman to go from 130 to 230 pounds. So when we look at that fact, we have to recognize that there is much more going on. That this is not a conscious intake of 48 extra calories a day that could be solved by just taking 48 fewer calories in a day. That there's something else going on here. If it was only 50 calories a day, diet and exercise would work great. Obesity would be a temporary inconvenience that could be solved with a couple weeks of buckling down. But that's not what it is, and we all know that. So why are so many people obese? Why have we seen such a dramatic increase? Why is it so hard to lose the weight on your own? This is a diagram that comes from a book I wrote called A Pound of Cure. And it's actually a description of how to change your diet in order to lose weight. And it came from my understanding of working with bariatric patients and seeing the difference that the different way that they lose weight compared to the way that people who are trying to lose weight on their own. And I will work with you certainly on your diet and make some diet changes. We'll talk a little bit about those in a few minutes. When we look at your weight, what we recognize is that everybody has a certain set point. That is a weight that your brain likes. Meaning if you walk into my office and you're 230 pounds, chances are your brain set point is give or take 230 pounds. And if I were to put you on a starvation diet and limit you, say, to an 800 calorie diet, what we would see initially is your weight would shift away from that set point. You might drop 10 pounds, 15 pounds, 20 pounds. The number is quite frequently the same within the same individual, but you'll see difference from person to person. On average, it's usually about 10% of your total body weight, so for a 230-pound woman, it would be 23 pounds. And what we see is as soon as you lose those 23 pounds, because dieting works at first, when you go on that 800-calorie diet for a week, maybe 2 weeks, some people can even last 3, they do well, and the weight comes off. But then some metabolic changes occur. And it's these metabolic changes that are what make weight loss so difficult. And it's that early success that people see that make us think that it's just a matter of diet and exercise. What we don't recognize is that although that calorie in, calorie out model works for about the first 15, 20 pounds, it stops working after that. So what we see happen after you lose the first 10, 15, 20 pounds is that you become exceptionally hungry. You become obsessed with food. It's all you think about. That is not because of a weakness of character. That's because of the release of hormones that are triggering your brain to seek out food. And we can measure these hormones, and we can demonstrate that when you go a prolonged period of time without eating, you are going to become obsessed with food. This is hardwired in our DNA. If you didn't have that and you were a caveman, you didn't stand a chance. So to be able to expect people to fight this is absolutely wrong. You cannot resist these temptations. You cannot resist the desires for food that occur when you starve yourself. The other thing we see, and everybody who's been on a starvation diet can attribute to this, your metabolism slows down remarkably and you have no energy. And you start dodging phone calls from your workout partner. Not because you're a lazy person, but because the hormones that are triggering you to seek out food are also slowing down your metabolism. Your metabolism is the sum of all the movements that you make. It's not this internal oven that burns inside you, but rather it's your body and more specifically your brain's push to have you move around and walk and climb steps and go exercise. If you have a lot of chemicals that are telling your metabolism to slow down, your brain is not going to want to move. And there's nothing that you can do about that, quite frankly. And so the most important thing is to not to try. We also have to recognize that if we overfeed, we should have equal and opposite reactions. We should have less hunger when we gain a few pounds after the holiday season. And we should have a faster metabolism. And in fact, this is very important for 2 reasons. Number 1, it's this mechanism that is broken in most overweight people. And number 2, when we do bariatric surgery, you'll see these mechanisms become very, very important. So this is something, again, I see in that same 130 to 230 pound transition in that female patient I referred to earlier. And what we'll see is that in high school, their weight is controlled. And then there's a shift upward over time. And sometimes there's a rapid shift upward. Sometimes there's a slow and gradual shift upward. But what we're seeing is that set point going from 130 to 140 to 150 pounds over the period of years, eventually getting up to 230 pounds. And there's a number of reasons why your set point goes up. In fact, very little of them have to do with what you're eating. And we can address those issues when you come in for a consultation, because it's going to be really important that we figure out why your set point went up so that we can prevent it from going up again after bariatric surgery. But what we find is that a gastric bypass and a sleeve gastrectomy, and to a lesser degree a lap band, will very rapidly shift your set point, and in my opinion it happens within a day or two, back down to a much healthier weight. And all the weight loss is a result of your body just shifting back to that new lower set point. Your body has this built-in metabolic thermostat that sets your weight, and if you're going to achieve weight loss by any means, food, exercise, or medications, or surgery, it's going to be important for you to actually shift your set point, not merely to starve yourself away from it. Now, there are 4 ways that you can shift your set point. We're going to go over all of them so you have an understanding of what the role of bariatric surgery is, because it's not bariatric surgery alone, it's bariatric surgery plus some of these other roles. I don't use medications in my practice, but I do use exercise typically later on, and I use food from the very beginning. So it's not a matter of should I have surgery or not, it's should I add surgery to my regimen of food change and exercise. And that's what we do at the Michigan Weight Management Institute. I'll talk briefly about medications. Again, I don't use them in my practice. These are 2 medications that I believe have a pretty profound impact on your set point. The first is phentermine, and it's also known as Adipex. And it was, when fen-phen was on the market, it was 1/2 of the fen-phen. And we see that this medication actually in a lot of patients can shift the weight down. Talk to some patients, they say, yeah, I went on this medication, I had no hunger. And I was exercising all the time. It was easy to exercise. I loved exercising. And it's because it shifts their set point down, which causes these hormone changes. And we can see great results from Adipex, but there's a very concerning side effect profile with this. First and foremost, it can increase your risk of having cardiac problems. If you have high blood pressure, it can be very dangerous. And then we also see significant personality changes. I have some patients who've told me it turned them into a lunatic. I've had other patients tell me they're cleaning their cupboards at 3 in the morning. So it's a very difficult medication, and for the most part we recommend putting patients on it for a short period of time and taking them off, and of course shifting your set point for a short period of time and then allowing it to rebound back is just not a good therapy. So whatever drug that ever comes out that allows our set point to shift down, and we don't have any real decent candidates right now, in fact there's not even a lot in the pipeline, it must shift your set point, and it must be a medication that you can stay on for the rest of your life. The other one that I see very commonly is nicotine, and the reason that people gain weight after quitting smoking is that the nicotine has been keeping their set point down, and when they remove the nicotine, the set point shifts up. And we have to remember, when your set point shifts up, you're in exactly the same position as if you were to go on a starvation diet. So we all know when you go on a starvation diet, you basically walk by a bakery and you gain weight. It takes nothing to put those pounds that you've worked so hard to get off back on. And when your set point shifts up, we'll see that same effect where you stop smoking, the set point goes up 10 or 15 pounds, and you are absolutely powerless to prevent that 10 to 15 pounds of weight regain. So I don't use drugs in my practice because there really aren't any good candidates, but it's important to understand what the current status is of drug therapy. Any of those other medications that prevent absorption of fat are merely inducing a starvation period. And that, again, starving yourself away from your set point is not an adequate way to lose the weight. Exercise. Now, I've chosen this picture, not a picture of a middle-aged woman on the treadmill, because the type of exercise that's necessary to actually shift your set point is vigorous and intense exercise. When you finish a workout, if you're doing it for weight loss, for 3 to 5 minutes afterward, you should almost feel like you have to lay flat on your back because you're too exhausted to get back up. It is taking your heart rate not up to 80% of its max, but as close to the max as you can get it. And it's something that I'll work with your primary care doctor to make sure that you're a viable candidate for, and we can talk about options for that. But quite honestly, a lot of patients come in, they've got orthopedic limitations, or their obesity is limiting them from participating in that type of exercise. And this is something that I typically use in patients well after surgery, after we get the weight off, after the orthopedic surgeons can address the needs, whether they need to be replaced or injected or whatever we can do to optimize the performance in a very careful way. It's generally not a effective first-line therapy. In 20-year-olds, it works great. 30-year-olds, it can be tough. Once you're in your 40s, being able to consistently perform this level of exercise becomes very challenging. In terms of dietary changes and food changes, the important thing to recognize with dieting is that it's not about eating less calories. It's about changing the content of your diet. I have a program that's outlined in my book called A Pound of Cure. Those programs are called the 12 Stations of Health, and they're 12 dietary changes. And I'll work with you to go through usually not all of the changes, but certainly a certain percentage of them, which varies from procedure to procedure. And we'll work in the office before surgery to make sure that you're well prepared. But again, importantly for food, it's about changing the types of food you eat, not the amount of food you eat. And now let's get to bariatric surgery, which without question is the single most effective way to change the position of your set point. And we see in this graph that if you start out, and again, here's a 230-pound patient. I do the gastric bypass, the sleeve gastrectomy, to a lesser degree the lap band procedure, and we shift the set point down. And a lot of times we'll shift it down, say 70, 80, 100, 150 pounds. Saw a patient in my office the other day who'd lost 200 pounds after surgery. It's a variable amount from person to person, but we'll shift that set point down. And your new set point, say, becomes 150 pounds. So you wake up from your surgery practically, and your brain says, I am not 230 pounds anymore. I am only 150 pounds. So when it looks at your current situation, it says, I am way, way overfed. And so, of course, when you're overfed, here are the changes. They're exactly opposite to the changes that occur when you go on a starvation diet. Instead of having lots of hunger, you have less hunger. And instead of having a slow metabolism, you have a fast metabolism. And that's exactly what we see after bariatric surgery. And I always joke with my office staff about, look at this patient, they've got the gastric bypass swagger. And what we see is 1, 2, 3 weeks after surgery, the patient walks into the office and their motions of their arms and their hips and their legs as they walk are exaggerated. And that's their body saying, I have all these extra calories. I got to figure out any way I can burn them off. And subconsciously, your gait or the way you walk changes in an effort to burn more and more calories. Patients tell me in those months after surgery, I have never had more energy in my life. And it's because your body is actively working to burn off all these calories. And this is exactly the opposite of what we see in patients who are restricting their calories. And this is the reason that bariatric surgery is so effective. Now again, once your set point is 150 pounds, it does not mean that the same factors that made it go up in the first place can't again raise this set point back up. And that's what's so critical about the lifestyle changes, that we have to identify issues. Sometimes they're food related, often they're not. Often they're medications or life issues or psychological stressors that cause your set point to go up, and we have to do our best to minimize those so that after surgery they don't go back up again. This is why some patients, about 25%, will regain a significant amount of weight after surgery. When we look at the long-term success, I like to break it down to patients who are less than 50 pounds overweight and those patients who are more than 50 pounds overweight. And of course, there's a lot of ways to be more than 50 pounds overweight. You can be 200 pounds overweight, like the gentleman I referred to a few minutes ago, or you can be 51 pounds overweight. And of course, we're going to have varying levels of success. What I find is if you have less than 50 pounds to lose, that on my program, we'll see about 1 out of every 4 patients really embrace it, make the lifestyle changes, and have great success. But the problem is as your weight goes up and the longer that you've been obese and the more issues you have that are pushing your set point upward, the more ingrained your set point becomes and the more stubborn it is. And I've had a number of patients who I know for a fact were following the rules, that they were eating the perfect 12 stations diet and the weight was not moving. They were doing their best to exercise but very limited. And what we see, even with a great dietary program like the one we run out of our office, is that there is a very large percent of people, 100, 150, 200 pounds overweight, who no matter what you do from a dietary and exercise perspective, will never lose weight. And that's something that most people have never, that's a concept people haven't grasped, that their obesity is resistant to diet and exercise. In fact, in order to restrict the number of calories enough to actually cause significant weight gain, you would put that patient in such a malnourished state that they would start to develop illness. And I think that's a really important thing to identify. And I'll work with patients, and that's part of what we'll do in the office is we'll see, let's see if your obesity is going to respond to food and exercise therapy. Let's do our best. Let's put these two very reasonable, very safe treatment plans in place. No judgment. Let's determine if it's going to work. Sometimes it does, and I've had some successes. I've had some amazing successes with patients 100, 150 pounds overweight. But a lot of times it doesn't, and that's where bariatric surgery comes in. There's 3 surgical options we're going to go over: the adjustable gastric band, the sleeve gastrectomy, and the gastric bypass. And the first thing I'll talk about is the necessary dietary changes in order to achieve success, because they're different, because each of these surgeries offers a different degree of impact on your set point. So depending on what influence the surgery has, the requirements for the dietary changes so that we can get the food component of the treatment to impact that set point to move differ as well. So the lap band is the least metabolically active. I think it is, certainly in a percentage of patients, does have some metabolic activity and will shift your set point. But it requires, on average, the greatest dietary compliance. And you'll see here are the 12 changes that we'll make that I recommend for patients trying to lose weight on their own. And we see that for the lap band, on average, most patients will have to adhere to 10 of those 12 changes, and some of these are pretty strict. So again, we'll go over these. As you get to the sleeve gastrectomy, we see that 8 of the 12 changes are necessary, because the sleeve gastrectomy is a powerful metabolic operation. People think it's just making your stomach smaller, but it's actually much more than that. The portion of the stomach that we remove does have a very profound impact on your set point, and we can see this in the chemicals that circulate that are responsible for moving your set point around. We see them change dramatically after sleeve gastrectomy. And with a gastric bypass, which is the most metabolically powerful procedure, we see that only 6 of the 12 changes are necessary. And I think that's an important thing to understand as far as your long-term weight loss success. This is obviously not a hard and fast rule that applies to everyone. And I can't guarantee all my gastric bypass patients that if you follow these exact 6 rules, you'll be fine and you'll never regain your weight. There's going to be variations. Some patients may only need to follow 3 or 4. Other patients, it may be 7 or 8. There's no way for us to predict this. So first, let's start by going to the video of the gastric bypass procedure. With a gastric bypass, again, it's done laparoscopically. About 99% of the time I do the procedure laparoscopically. We put 5 or 6 small incisions in the plastic tubes, and through the plastic tubes we'll introduce our instruments which allow us to manipulate our intestines. And what we do first is we turn the full-size stomach into a very small stomach pouch, and then the remainder of the stomach sits there. I refer to it as the remnant or the lower pouch. And we'll divide the intestine downstream and hook that piece of intestine up to the small stomach pouch and then connect them together so that instead of a straight line as your intestines normally form, they form a Y. And it's important to note we have not removed any of the intestines. So when you eat the food, which is blue, goes through the small stomach. It stretches the stomach out, which releases hormones and makes you feel less hungry. And then the enzymes come in yellow. When the food and the enzymes mix together, then you get absorption. If you have just food alone, there's no absorption. And just enzymes, there's obviously no food. But only when the two come together at the bottom part of the Y do you have absorption. And by rearranging the flow of the enzymes and the food through the intestine, we trigger the signals to your brain to lower your body's set point and decrease your hunger and increase your metabolism. Okay, let's review the lap band procedure. Before we do, I'm going to introduce you to the lap band device. There's two components. There is a silicone ring right here, and this goes around the stomach. It's wrapped around the stomach. I'll show you exactly how that works in a second on the video. But this has an inflatable bladder. The bladder is connected by a long tube to this device, which is essentially, we call it the port. And that port will be implanted just underneath your skin in your abdominal wall. Now, in about 98% of patients, you cannot see it. And I'll tell patients that only you, me, and your spouse will know where this thing is. And it's not something that you can see. I have patients who wear a two-piece bathing suit, and it's not visible. Generally in men with a very thin abdominal wall, sometimes you will see a little bit of a button effect. But it's not a visible component. It is, however, something you can feel, and it sits just underneath the skin. And in the office, I can adjust the tightness of the lap band by injecting fluid in through this port. So let's take a look at the video. So with the lap band procedure, we make 5 small incisions in the abdominal wall. And then through those incisions, we put things called trocars, which are plastic tubes. This is laparoscopic surgery. The advantage being there's not a large incision, but a few small ones. And through these trocars, we put our surgical instruments that allow us to manipulate the stomach and the intestines. And the way the lap band works is we start by wrapping the band that we've introduced through one of the trocars around the very top part of the stomach. You'll see as it comes in, it really leaves a very small pouch of stomach above the band. And then that band is connected to a long tube that separates things between the upper stomach and the lower stomach. And that long tube is brought out through one of the incisions and then connected to this port. And the port is what allows us to adjust the amount of fluid in the band and therefore the tightness of the band. And we'll adjust this based on your symptoms. If you're having a lot of hunger, we can put more fluid in. If you're having a lot of heartburn, we can take some fluid out. And the band will slow the progress of food. Now again, it does not block the food. In the office, we can then, through your skin, inject some saline into the port, which will tighten down the band and further restrict the flow of food through the stomach. The idea being that by only being able to eat smaller amounts of food, you will lose weight. So the newest procedure is the sleeve gastrectomy. It's a very exciting procedure. We're going to talk about that. Let's first start by looking at a video. With the sleeve gastrectomy, again, it's done laparoscopically 99% of the time. We make 5 small incisions, sometimes 6, and put plastic trocars that allow us to introduce instruments and manipulate the stomach. Now, one thing that's important to understand is that it's a sleeve gastrectomy. The gastrectomy means that we remove a large part of the stomach. Approximately 2/3 of the total volume of the stomach is removed. And we do that by creating a long staple line through the stomach, which turns the stomach, instead of a large football-shaped bag, into a skinny thing around the size of a garden hose. And that, again, it's important to note that that piece of the stomach is removed, which makes this procedure completely and totally irreversible. You cannot pull the stomach back out of the formalin and sew it back in. And then with this new skinny stomach, it's going to limit the ability for you to eat large portions of food. But more importantly, by excluding and excising the portion of the stomach that releases a lot of the hunger hormones, you're going to shift your set point down and have less hunger, and in fact also have a faster metabolism. When we look at the weight loss after these 3 surgeries and we compare them, what we see is there is some difference. And I think it's very important for you to understand the difference between the weight loss. Without question, we see the least amount of weight loss with the lap band. Now, one thing that's important to understand about the lap band is that there is a significant amount of variation from patient to patient, more so, I believe, than with the other procedures. I have a third of lap band patients who do unbelievably well. And if I had to think of my thinnest patients in my practice, the majority of them are lap band patients. There's a small subset of the lap band patients who lose a tremendous amount of weight and have an incredibly significant effect. And essentially what I think is happening with these patients is they have a very profound shift in their set point as a result of the surgery, because the weight loss is easy for this group of patients. That's a little less than, I think, a third of all my patients will have that very significant and real impact. Now, with the other third, the second group, there's certainly a shift, but what I find is it's about 40 to 50 pounds. And they do great to lose that first 40 to 50 pounds. But that's where the effect of the band stops. And in fact, by tightening up the band, we don't get that set point to shift down further. And at that point, we're really dependent on food and exercise to get the rest of the weight off. And these patients, I think, are satisfied with their lap band, but not overwhelmed with their success. And I think they get a little frustrated. But we do definitely see a good 40 to 50 pounds of weight loss, and that's without question caused by the band. The last third of the band patients lose maybe 10 to 20 pounds and struggle. And the problem is that it's very, very difficult, in fact impossible, for me to tell you in the office before the surgery which of the 3 groups you're going to be in. When we look at the sleeve gastrectomy, what you see is that the data points stop after around 5 years. And quite honestly, I believe that the weight loss is permanent, but I do not have the data to prove it the way I do with the gastric bypass, which causes a little more weight loss, on average of between 10 and 20 pounds of difference between the sleeve gastrectomy and the gastric bypass. With the gastric bypass, we do have the data for the long run to show that this is a permanent and durable operation. This is a very important slide. This is, how do I decide which procedure to have? And when I start with 2 groups of patients, and these 2 groups of patients I believe should have a gastric bypass. The first is diabetics, and the second is those patients with GERD, which is gastroesophageal reflux disease, also known as heartburn. As far as the diabetics go, if you take insulin or are about to be placed on insulin, I believe that since this is such a dangerous disease, that we should give you the best chance we have of getting off insulin. And in fact, the gastric bypass typically will get patients off their insulin within 3 to 5 days of surgery. And it's because of these immediate shifts in your metabolism, the same ones that shift your set point down to a much lower rate, also improve your glucose metabolism to the point that you can come off insulin before you've even lost a significant amount of weight. And the gastric bypass is a very, very powerful operation for diabetics, and if that's your primary reason to do it, then that's the operation we're going to choose. The second group is those patients with severe heartburn. I'm not talking about every now and then, maybe once every other week, you could have an episode of heartburn that you have to take some Tums for. I'm talking about patients who wake up daily with heartburn, who are always popping Tums, who always have burning in their chest and are constantly modifying their diet in order to prevent themselves from suffering from heartburn. If you have significant heartburn, I think a gastric bypass, which will actually improve heartburn, is a much better operation than the other 2, which tend to, if anything, worsen heartburn. If you have a slow metabolism and are typically very resistant to losing weight, even 10, 15 pounds can be very difficult for you, a gastric bypass is the best we have. Patients with a limited mobility also, I believe, benefit from a gastric bypass, because by limiting your mobility, you're limiting your ability to increase your metabolism. So we have to give you every effort we can in order to lose the weight. And again, the most effective procedure for weight loss, based on those 3 curves I showed you before, is the gastric bypass. There is a small risk, typically around 1 to 3% of a serious complication, and that number really depends on your weight and your age and some of the other factors such as previous surgeries. And in the office, I'll generally kind of let you know whether you're a low, medium, or high risk patient as far as the surgery. For the gastric band, I think young active patients anecdotally form the majority of that group of the 1/3 of patients who have the best results. But again, that does not mean that all young active patients end up in that group. It's very hard to figure out who's going to really benefit from the lap band. But if I had to put any characteristics to that group, they would be young people who are able to exercise. The lap band is without question the safest procedure. It is probably one of the safest surgical procedures that is performed today. Finally, for the sleeve gastrectomy, if you've had previous abdominal surgery, now that does not mean your appendix out or a hysterectomy or your gallbladder out. That means major abdominal surgery with midline incisions, colostomies, big hernias with mesh, not a small umbilical hernia, but a large hernia through the incision that's been repaired with mesh. A lot of times, I would recommend a sleeve gastrectomy for those patients because a sleeve gastrectomy typically can still be performed laparoscopically, where a gastric bypass where we need to manipulate the intestines will not be able to be performed laparoscopically because of the scar tissue. I think patients with a faster metabolism and more importantly a lower BMI, I think if your BMI is less than 50, that tends to make you a better candidate for a sleeve gastrectomy. And we have evidence that shows that the patients with BMIs in the high 30s and 40s have a really great response to the patients compared to the patients with the bypass. Limited to no heartburn is important. We can talk about it because factors like a hiatal hernia can impact that decision, but in general, I do not like to do a sleeve gastrectomy on patients with significant heartburn because I can make that worse, and that can be a really frustrating problem. You're having this operation to make your life better, and if I make it so that you have pretty significant heartburn, that ends up making your life worse because it can be miserable when it's severe. Finally, limited access to bariatric surgeons because the long-term complications from a sleeve gastrectomy is the lowest of the 3 procedures. If you're moving to a place where you're not going to have access to bariatric surgeons, because unfortunately they are not in every town in the country, then I would recommend a sleeve gastrectomy over the other 2 procedures. And there is a very similar risk with the sleeve gastrectomy to the gastric bypass. I really don't say one procedure is safer than the other. I think they're equivalent in safety. That's an important concept to understand. As far as the time off work, the recovery from a gastric bypass and a sleeve are very, very similar. I recommend 2 to 3 weeks off of work. In rare circumstances, patients will take 4 to 6 weeks off of work. What I find is that typically if you have the sick time and are able to take 3, 4, 5 weeks off of work, most often you will, and I think you'll benefit from it because you're going to be able to really commit yourself to the dietary changes and recovering and walking without having to focus on work. But those patients who do want to go back to work at 2 weeks, at 3 weeks, really tend to have no problem. With a lap band procedure, it's 1 week you can get back to work. It's pretty quick recovery. I've even, in extreme circumstances, done the surgery on a Friday and had patients back at work on a Monday. As far as the complications go, this is kind of the scary part of the presentation, but it's absolutely critical that you understand that this is major abdominal surgery, all of the procedures, and that problems can occur. Problems can occur right after the surgery. Problems can occur down the line. The most significant complication from a gastric bypass, and the one that you hear the most about, is a leak. And that's where typically it occurs between the stomach and the small intestine where it's sutured together. When I do the procedure, I will test the anastomosis, which is what we call the connection, by placing an endoscope through your mouth while you're asleep and blowing up air into the stomach and having it clamped off just past the connection point. And I'll put everything underwater and I'll look at it distend and I'll look for any air bubbles which would show that there's a leak. So the one thing I can promise you is that when I finish your surgery, there won't be a leak. over time, in about 1 in 200 patients, 0.5%, and that's what's listed here, those sutures, for whatever reason, can pull through. And if they do pull through, this is the scary complication. You can end up in the ICU needing to have reoperations, and instead of a 2 to 3 week recovery, we're really talking about 2 to 3 months, and in rare circumstances, these patients can die. The mortality rate from a gastric bypass surgery, all comers, including the highest risk patients, is about 1 in 400 in the state of Michigan, and we track that data very, very closely. The next complication is an abscess. That's about 1 to 2%, and essentially what that is a very small leak where the stitches will separate at in a very small way, and your body will wall off the infection. It typically will require a procedure where the radiologist will drain it and place a catheter in it. And again, it's not a life-threatening problem, but it certainly is something that's scary, and I would never want to see a patient go through that. Thankfully, it is pretty rare. But it will certainly take that 2 to 3 week recovery and stretch it out to 4 to 6 weeks. We do see bleeding. Now, I use 3% as a number. However, that does not mean 3% of the patients get blood transfusions or 3% of the patients need to be taken back to the surgery to have the bleeding stopped. That means 3% of the patients have a significant drop in their blood count after surgery. About 1 in 200, or 0.5% of all patients, will need to be reoperated or aggressively transfused for bleeding. As scary as that sounds, it's actually a solvable problem. It can typically be handled laparoscopically and usually ends up having a good long-term result without a very prolonged period of recovery, maybe instead of 2 to 3 weeks, 3 to 4 weeks. Blood clots are very concerning. They start in the legs and can break off and go to the lungs. We'll be able to categorize you using a risk calculator that we use into either low, medium, or high risk. If you are low risk, the risk of having a blood clot is 1 in 400 or 0.25%. As you get up to medium and high risk, we'll give you the numbers, but it's usually in the range anywhere from 1 to 5%. And if you've never had a blood clot before, very likely you're going to be in that low risk category. We put all patients on blood thinners actually even before the surgery and immediately after the surgery. And then a small percent, those who are medium or high risk, will go home on a blood thinner. Strictures are narrowings of the connection between the stomach and the intestines. 5%, probably over the last year or so, I've been around 3% in terms of strictures. And what happens is when I sew the anastomosis together, I always sew it over a tube so it's exactly the same diameter. However, at about 4 to 6 weeks after the surgery, it can narrow down and scar down. And when that happens, it can be difficult for you to continue to advance your diet. There's a slow progressive advance of your diet over the first 3 to 4 weeks after surgery. And what happens is essentially you're making nice steady progress, and then at 4 to 6 weeks, you start having more trouble keeping food down, not it continuing to get better as it should. And if that becomes, a lot of times that will just go away on its own, but if it becomes so significant, I'll have to take you to the endoscopy suite. This is an elective procedure that we schedule, and you aren't admitted to the hospital. I'll put the scope in and blow up the balloon and stretch out that anastomosis. And in rare circumstances, we have to do that twice. And in fact, what I find is that if this is the first time ever having the bariatric surgery, you've never had previous stomach surgery in the past, the rate of this is very, very low. If you've had previous surgery, if this is what's known as a revision surgery, where you had, say, a lap band and weren't able to lose enough weight and are being converted to a gastric bypass, that's when I see a much higher rate of stricture. Ulcers also, patients can develop an ulcer in the intestine. We see this most commonly in smokers. I actually have 2 criteria before I'll do surgery on you. Number 1, you have to have quit smoking. And number 2, you cannot be actively drinking soda pop. If you have ever been a smoker, and the more recently you've been one, the rate of having an ulcer goes up higher. We really typically just see these patients in smokers or those who take a lot of what are known as non-steroidal medicines like aspirin or ibuprofen or Motrin. The last item, severe vitamin deficiencies, we see in about 1%, actually a little bit less than patients. And you know, a lot of people kind of have in their mind, oh my God, what's going to happen? What if I lose too much weight? When's the weight loss going to stop? And when we recognize that this is a shift in your set point, it makes sense that you're going to lose the weight and then it's going to stop as you get close to the set point. And when you get close to the set point, your hunger will come back and you'll start to see the normal fluctuation around your set point that you did before surgery. And this, in fact, is exactly what we see. In rare circumstances, people will can acquire severe vitamin deficiency. What I do with my patients, which is actually a little bit different than what most bariatric patients do, is I really get patients on fruits and vegetables very early on in the process rather than focusing on protein and vitamin tablets, because nutrition is much more than just the 20 or so vitamin levels that we supplement in a pill that everybody takes. There's thousands of other compounds, and I found that by getting patients on these fruits and vegetables very early, you can prevent that kind of drawn and wasted look that you'll see occasionally in bariatric patients. And that's, again, where the nutritional component comes in, that by eating lots of fruits and vegetables, you maintain good nutrition as the weight comes down. If you stick to the heavily processed protein shakes and rely on vitamins as your primary source of nutrition, you end up running the risk of severe vitamin deficiency. So this 1% is, I think, even lower in patients who are able to eat fruits and vegetables as part of their diet. For the gastric band, the most significant issue that we'll have in the first 1 to 3 years is something called a slip. And essentially the band slips out of place. And when that happens, the band either needs to be removed or replaced. And we'll see that in about 1 in 20 patients. And what will happen is the patient will have a hard time swallowing and will start developing significant gastroesophageal reflux disease. We'll also see erosions. Less than 1% of all patients will have erosions, where the band will essentially erode through the stomach wall and more or less get infected. And the band in that situation has to absolutely be removed. It can be put in several months down the road, but it does require removal. We'll also see infection in the immediate process over the first, say, month to 2. It's typically the port that gets infected, not the band, and oftentimes we can swap out the port and avoid having to remove the part that goes around the stomach. What we also see down the road, and this is more 3, 4, 5 years down the road, is esophageal problems. And we'll see about 10% of all patients will develop some issues where their esophagus doesn't function properly, and we have to loosen the band, which of course can potentially result in weight regain. And this can be a very, very frustrating problem. What we see long-term with complications is that the lap band, which is initially the safest operation, has the highest rate of long-term complications, and I think that's an important component to understand. Treating esophageal problems can be very frustrating, but it can be done successfully too, and I've gotten a number of patients through these problems without having to remove their band by training them to eat differently and adjusting the fluid in an appropriate way. And then the final thing we already talked about is that one-third of patients who really just don't lose any weight from the very beginning. And the band does not have a significant metabolic impact, and this can be a very frustrating problem, and one I certainly it's one that's very upsetting when we see it happen. For the sleeve gastrectomy, the complications are actually fairly similar in terms of the type that we see with a gastric bypass procedure. The first is the leak rate, and I think it's important to recognize the leak rate for a sleeve gastrectomy is about 0.75%. It's still very low, but it is a little higher than it is for a gastric bypass. And I think that's important to recognize. We see a little less bleeding because there's less things that can bleed after a sleeve gastrectomy, but we still will see bleeding. The rate of blood clots is very similar to a gastric bypass and also subscribes to this low, medium, and high risk groups. But what we see is on average about 25% more blood clots with a sleeve gastrectomy than we do with a gastric band, and the reason for that is unclear. So again, with the sleeve gastrectomy, although it's very slight, we do see a little bit higher initial complications, but in fact the delayed complications that happen 1 to even 10 years down the road, we see a much lower rate with the sleeve gastrectomy. So when you average everything out, it ends up being very, very similar in terms of their complication rates overall. We also will see strictures in 3 to 5%. Now, a lot of times these will resolve spontaneously, but although when I talked about strictures for a gastric bypass, those strictures tend to be a very short segment and will respond very nicely to balloon dilatation. Strictures in a sleeve gastrectomy tend not to respond nearly as effectively and may require additional procedures beyond just a dilatation with the endoscope. And then finally, heartburn. We do see about a quarter of the patients will have some degree of heartburn afterward, but this will go down to around 10% long-term as the weight comes off. As far as post-operative care, when we're talking about the gastric bypass and the sleeve gastrectomy, we see very similar problems, very similar recoveries. We see some patients, I'll get a swallow study the morning after. I actually get it on every sleeve patient and maybe about 1/4 of all gastric bypass patients. If you're a higher risk patient based on your BMI or previous surgery, or perhaps your stomach wall is thin or there's something else that's concerning to me, I will do a swallow study where you go down and drink contrast and we look at it under the x-ray. But for the majority of the gastric bypass patients, I don't get a swallow study. Also, the JP drain, I don't use a JP drain at all in the sleeve gastrectomy, and I do it in selectively. Typically, those higher risk patients, again, I'll leave a JP drain to, God forbid, suck out any infection should the staple line or the suture line break down. Some patients require blood thinners, those medium and high risk patients. A lot of people think that after surgery there's going to be a prolonged period where you can't eat or drink anything, but in fact I'll give patients ice chips in the recovery room if they want them. And you're allowed to wet your whistle that night, and you can have really as many ice chips as you'd like, and the next morning we'll typically start you on Jell-O and liquids, and within 2 to 3 days you'll be on your protein shakes and slowly advancing your diet from there. I typically do the operations on a Tuesday, and most patients will go home on Thursday, so it's only a 2-day hospital stay. With the gastric band or the lap band procedure, you get clear liquids immediately afterward. There's no swallow study. You are walking within, say, 2 hours of surgery and go home the next morning. The initial surgery, very, very easy to recover from. As far as the follow-up care, we're going to see a lot of each other. We actually see a lot of each other before the surgery, and we see a lot of each other after the surgery. I'll see people for their 1-week post-op visit, and then at 1 month, 3 months, 6 months, 9 months, 12 months. In the second year, I'll often see patients every 6 months, sometimes even every 3 months. If we're not where we need to be with the nutritional changes, we'll continue to work on those. And I think one thing that's absolutely critical is that you recognize that I will be your weight loss doctor forever. And that if 5, 10 years down the road, you start to gain some weight, you start to see some warning signs slip in where you're starting to not eat exactly the way we've always talked, and there may be other stressors that are triggering this for whatever reason. You come in for an appointment. We'll figure it out. I have a very important rule in my office, which is I don't judge. I don't blame the patient for their obesity. Unfortunately, one of the few doctors out there who doesn't, but I truly believe that if we're going to look at this as a metabolic disease, which from my perspective this really is for the most part, that we can't make judgments about patients. It's not your fault. Doesn't mean you're not part of the solution, and changing your behavior isn't critical, and then I'm going to hold you accountable for those behavior changes. It just means I can't be one of those people who drags you down because of your weight. There's enough of those people out there already. As far as the dietary changes we see after surgery, we implement a slow return to a solid diet that typically takes 4 to 6 weeks after. We'll start with some soft dairy and some sugar-free applesauce. We'll move into some cooked vegetables. And again, I'm getting patients on fruits and vegetables as early in the post-operative process as I can. Eggs can be the next step. Sometimes poached egg works better than, say, scrambled eggs. Then fish, which is typically softer. And finally chicken, which is kind of the hardest thing to get down. People will be able to eat chicken, say, 4 to 6 weeks after the surgery. So again, it's a slow, progressive return to your regular diet. As far as the timeline for surgery, the first step, I believe, is to watch the seminar online or to attend one of our live seminars. We typically have two a month. And just because you watched it online doesn't mean you can't come in for a live one. A lot of times I'll stay after the seminar and answer any questions, and you obviously have the potential to watch to ask questions as we're going through the seminar. And then we'll have you come into the office, and this is where we spend quite a bit of time with you, and we try to identify those factors that have resulted in your obesity and make a plan for the food and the exercise treatment, work together for whatever the insurance company mandates as far as preoperative counseling, and then we'll typically do the surgery. There's often a lot of other components, and I'm happy to say we really have a fantastic office staff who is very skilled at identifying the pitfalls and nuances of obtaining insurance authorization for this procedure. And we'll work very closely with you to make sure that your insurance company covers this. And we'll work very closely with your primary care doctor, who really has to be part of the process. This is our website and our phone number. I've got my email up here if you have any questions, as well as my office manager, Carol Finkelstein, who handles the insurance questions, and she's an excellent, excellent resource as well. So I'd like to thank you very much for your attention.